So continuing with our discussions on oral surgery, the topic for today is major surgical procedures in oral surgery or oral and maxillofacial surgery. So the topic discussed in this chapter will be BSSO, a very commonly asked question in oral surgery, especially for AIMS. So see, this chapter is more important for AIMS than NEET. Definitely the simple areas are important for a NEET as well. Okay, so the BSSO, that is the bilateral sagittal split osteotomy. Then you have got something known as IVRO. Okay, IVRO, that is intraoral vertical ramus osteotomy. So it's an, I won't say modification, but an alternative for BSSO in many cases, not all. Then you've got inverted L osteotomy, again another alternative. We'll see the indications very soon. Okay, inverted L osteotomy. All the three are done on the mandible. Then you've got again another procedure on mandible, that is genioplasty, done on chin. Then we have got some procedures on maxilla. We've discussed this in the fractures of midface, that is Lefort 1 osteotomy. Distraction osteogenesis, now it can be done. It's an amazing procedure, distraction osteogenesis, and a very important topic for INI-CET, okay, for AIMS. Then you've got TMJ surgeries and neocondylogenesis. I would say the most important chapter for INI-CET. Okay, we'll discuss one by one. Now, another thing, yes, a little significance, lip reconstruction surgeries. Then, yes, a very confusing area for many students, that is graft for jawbone reconstructions. Okay, where we'll be discussing on fibula graft, rib graft, scapula graft. Okay, so then we have got another, that is iliac crest graft, and something related to that, which is the clamshell flap. Okay, so let's start our discussion with the first topic, which is the BSSO. So as I've told you, the first topic is BSSO, bilateral sagittal split osteotomy. We'll understand this better. It was first described by a person called Obwexer, a very famous person in oral surgery, and Trauner. So Obwexer and Trauner. And it was later modified by another three people, that is Dalpont, okay, then Hunsack, how you pronounce it, it's up to you, Hunsack or Hunsack, and Epker, okay, and Epker. Now, basically there is an intraoral incision, okay, this is accomplished through a transoral, or we call it as through oral cavity, that is transoral incision, okay, and the incision is very similar to what you're going to see next, that is for IVRO. So it's a similar incision there, okay, this is the incision given, no, very typical simplified incision, okay. You don't need to go into too much of details. Okay, what is more important is the osteotomy, how the bone is cut. Okay, so there is a clear difference between the osteotomy of the BSSO and IVRO. That's what I'm going to discuss first. What's exactly the difference? In case of BSSO, which is called a bilateral sagittal split osteotomy, what does it mean? Here, the ramus, it divides the ramus in a sagittal plane. Very important. I'll explain, I'll tell you this, okay? How is it? Then you've got IVRO, intraoral vertical ramus. So it's, see, the vertical. So this divides the ramus in a vertical plane. So what it is? See, this is the sagittal plane. This if you just have studied, we have studied this, isn't it, in various topics. This is a sagittal plane, isn't it? So if you're just, incising it in a sagittal plane, it's called BSSO, okay? Whereas if you're just or not incising, we are cutting the bone in a vertical plane, it's called IVRO. Okay, so this is the sagittal plane, and the second one, this is the vertical plane. So that's very important to understand. Okay, now, so let's understand more clearly how the BSSO osteotomy is, and then we'll come later on to IVRO. This is the difference basically I want to tell you. So the BSSO osteotomy, the ramus as I've told you, is divided how? Sagittally, isn't it? It's divided sagittally. And then we have to understand how exactly sagittally. Okay, so there is a horizontal osteotomy and there is a vertical osteotomy to get the entire sagittal split. Okay, I'll tell you, don't worry. You'll understand those in very clear method. So there is a horizontal osteotomy on the medial aspect. Okay, medial aspect. So if you just see this, okay, this is the horizontal, horizontal. This is vertical and this is horizontal, isn't it? So on the medial aspect, you can clearly see there. Okay, I'll just enlarge it for you. So this is the horizontal incision. Horizontal cut, horizontal osteotomy. Okay, and on the lateral aspect, so this is the lateral aspect where you see the vertical osteotomy. This has to be very clear. So on this, please note, on this side also there is an horizontal osteotomy. Here also there is an horizontal osteotomy. It's bilateral, isn't it? And that's on the medial side. On the lateral side, you have got a vertical here and a vertical here. So on the lateral aspect, there is a vertical osteotomy, and these two are connected by anterior ramus osteotomy, and they are separated. Okay, so what are they? You have got a horizontal osteotomy on the medial aspect, which is very clear here. Then there is a vertical osteotomy on the lateral aspect, and then you have got an anterior ramus osteotomy to connect them. And then you split the medial and lateral cortex. Okay, you split it and you can advance it or set back it, it's up to you. Okay, so that's basically the BSSO osteotomy. Now, a little bit more. Vertical osteotomy, same thing I'm saying. Vertical osteotomy on the lateral aspect. Okay, and they are connected by what? Anterior ramus osteotomy. Now, the next thing what you do is, as I've told you, the lateral cortex is separated from the medial cortex so that you can advance the mandible. Mandible is advanced, or you can set it back, push it back, okay, for correction of whatever, isn't it? Correction of mandibular deficiency. See, if it is a it's a mandibular deficiency, you can advance it. If it's a mandibular excess, you can set back it. Okay, so that's what they are saying. Okay, so this is basically the osteotomy. It's a most commonly used surgical technique for mandible. Okay, it's for lateral like asymmetry corrections, for anteroposterior corrections, everything. And when this is not feasible, this BSSO if not feasible, then you go for other surgeries like IVRO mostly. Okay, and some specific indications also there for other procedures. So coming on to the next surgical procedure, which is IVRO, intraoral vertical ramus osteotomy. And it was first described by a person called Winstanley. This is important. This was asked for you. Okay, in a question I'll discuss later on. That is Winstanley, 1968. Okay, now the indication, the primary indication of IVRO is a mandibular setback procedure. The setback, if there is a mandibular excess, okay, you set it back. That's a very common indication. Now, more importantly, we'll come to more indications later on, but more importantly, what is the advantage of using IVRO over BSSO? This is very important to understand. Though BSSO is a very versatile technique, there is some disadvantages for it compared to IVRO. Okay, but now IVRO have got its own problems. I'll discuss later on, but let's understand the advantages. Okay, the main thing is it is very fast and very simple. Okay, faster and simpler procedure than BSSO, bilateral sagittal split osteotomy, or you can call it another name, that is SSRO, sagittal split ramus osteotomy. Okay, either you can get it. Now, next is rehabilitation time is much shorter. Okay, because just a vertical cut is given. You are not separating the cortex and all. It's not a complicated procedure there. Then more importantly, much more importantly, and this is a very important question as well, there's a lower incidence of inferior alveolar nerve injury. You know how the cortex is splitted, isn't it? You have to split the cortex, and when you're splitting, there is this anterior ramus osteotomy and the cortex is splitted. There's high chance that it can injure the alveolar nerve. Okay, so let's understand the procedure a little bit. Okay, the basic procedure, the incision I've told you, it's same as the BSSO. So let's understand what is exactly the incision done here. Okay, the ramus is exposed, you know that you have to cut it vertically, and there is a intraoral incision. Now, where is the incision done? At the level of mandibular occlusal plane. So see this. This is at the level of mandibular occlusal plane. Where exactly? Now it's medial to the external oblique ridge. So you have, this is the external oblique ridge. So you go medially here inside, okay, and you start from, so you have to expose it, you start it from lingula here, okay, this lingula is not shown here. You start from lingula there, okay, anterior to lingula, and you cut it, and coming up to a particular point. So that's medial to the external oblique ridge. I'll show you till what? Till the mandibular first molar. Now in the options they will give you mandibular second molar and all. Please make sure that it is till the mandibular first molar. So how it goes is, it starts from the medial aspect, medial to the external oblique ridge. So it should start at the level of occlusal plane, isn't it? And it comes there, and you just need to go for a vertical incision and expose it, this thing. Okay, so here it is not shown, this part. Okay, this comes like this. Okay, so the key here is, the most important factor you have to note here is till the mandibular first molar. If you want to forget the rest of it, it's fine, but this mandibular first molar, you have to remember it. Okay, now how is the bone cut made? How do you cut the bone? It's from the sigmoid notch. So if you have studied the anatomy, this is the sigmoid notch, isn't it? So you have to cut it vertically from the sigmoid notch down to the angle, okay, and carry it inferiorly to the region of mandibular angle. So this cut it. Then now you can advance this portion, isn't it? Now it has got its own advantage. We'll come to that. Okay, so this is the cut being made here. Okay, and you can advance this particular segment anteriorly. Okay, so that's it. Now, what are the indications? We said most common is to advance or set back the mandible, okay, posteriorly. So it's a quick procedure to set back the prognathic mandible. And if you have got a mandibular asymmetry, you can rotate one side of the mandible. So how do you do that? So I've told you this. You cut one side, you give an osteotomy on one side, and you can rotate this like this, isn't it? If there is an asymmetry there, or if you want to rotate it on this side also, you can do it. Okay, provided you take more bone from here. So you can do it for a mandibular asymmetry, to rotate one side of the mandible. And the main application compared to BSSO, so the other two procedures you can do it with BSSO also, but one application which stands out for IVRO is that if there is a mandibular excess, okay, along with or concomitant with widely flared ramus, okay, you have, so this is the picture there, you